effectiveness of reduced dose slow infusion intravenous alteplase regimen in patients with acute pulmonary embolism at intermediate high risk. So high-risk pulmonary embolism presents with hemodynamic instability and requires urgent perfusion, but intermediate high-risk pulmonary embolism is hemodynamically stable initially, but there is a risk of progression to shock. And considering the high risk of bleeding, major bleedings, intracranial bleedings, current guidelines do not recommend full-dose thrombolytic treatment as the first-line treatment option. And it is also reported that full-dose treatments reduce mortality, and it is associated with better clinical outcomes. And in this study, we aim to assess the safety and effectiveness of reduced-dose systemic thrombolytic therapy in achieving effective reperfusion acute intermediate high-risk PE. So this is our patient selection criteria. We classified patients as, we evaluated patients classified as intermediate high risk according to the ESC guidelines. And if a patient fulfills one of those criteria, systolic blood pressure below 110 millimeter mercury, desaturation on room air, lactate above 2 millimoles, respiration rate about 20 breaths per minute, and heart rate about 100 BPM, we include those patients in our study. And exclusion criteria were definite contraindication for systemic thrombolytics and symptom onset longer than 14 days. So we identified 124 patients, and those patients received 25 milligrams of alteplase intravenously over 4 to 6 hours, along with standard anticoagulant regimen. After completion of this infusion, we performed a bedside examination, physical exam, and if a patient is still tachycardic, desaturated on room air, or presented with signs of hypoperfusion, another infusion is repeated until we reach a total dose of 75 milligrams. Those are baseline characteristics and clinical variables of our patients. 30% of patients presented with syncope, 50% with deep vein thrombosis, 5% of patients with history of malignancy and orthopedic fractures. Median symptom duration was 3 days. Average heart rate was 112, systolic blood pressure was 123, saturation was 89, and lactate levels and troponin levels were elevated in those patients. As for the imaging, we used Canadian score to evaluate the pulmonary artery thrombus burden. Pulmonary arterial pressure on echo was elevated, 50 millimeter mercury, and RV-LV ratio was 1.26. Our median dose was 50 milligrams, and median infusion time was 6 hours. Heart rate, systolic blood pressure, and oxygen saturation were all improved. Final heart rate on average was 86, and final saturation was 96%. There was a marked decrease in Canadian score. We observed almost 40% of reducement in Canadian score. Pulmonary pressure was reduced by 18 millimeter mercury, and most importantly, RV-LV ratio was decreased by 30%, and there was also an improvement in right ventricular function. As for the safety outcomes, we only had one intracranial bleeding, which is a cerebellar hemorrhage, and no surgery required. The patient was discharged without any sequela. Total major bleedings observed in 6 patients, which is 4.8% of total number of patients. And in hospital death, 6 patients with 2 due to major bleedings and 4 due to hemodynamic decompensation. In conclusion, the use of systemic thrombolytics demonstrates beneficial hemodynamic and clinical effects, potentially improving the prognosis for patients with acute intermediate high-risk PE, and reduced dose alteplase regimen could be a safer alternative to full-dose thrombolytics in terms of reducing hemorrhagic events, particularly in specific subgroups of patients with intermediate high-risk PE. Thank you for listening.
Thank you so much for this excellent presentation. My question is, if the patient get worse during your treatment, what's your next step? How you progress and what's your next step?
All of those patients are in intermediate high risk status in our study, and if a patient deteriorates, we only have two options. First one is catheter-based treatments, and the second option is to complete the infusion to 100 milligrams. So that depends on the on patient status, but we choose either one on a patient basis.